So the natural history of the disease, not all prostate cancer is treated equally. And if you come and talk to me and if you have a diagnosis of prostate cancer, we go through a long conversation about your particular type of prostate cancer. So we go from A to Z as to where you are in your standing of having prostate cancer, and then we discuss, what's going to be best for you. Not all prostate cancer needs surgery. Not all prostate cancer needs radiation. Some prostate cancer will just watch. We do what's called active surveillance and watch it. And it's all based off of the individual's prostate cancer. So it's not like some other cancers, breast cancer or lung cancer, where you kind of have aggressive treatments. And again, that's because of the natural history of the prostate cancer is that not all of them is going to be life-threatening. The prognosis is what everyone wants to know about. Doc, if I have prostate cancer, how long am I going to live? Unless we have the entire prostate out, the best thing that we actually have at that point in time, if you're diagnosed with prostate cancer, is the biopsy results. Because that's a snapshot of your prostate cancer. That is an actual tissue diagnosis from samples of the prostate cancer, and it's been graded under the microscope. It's been evaluated based off of how aggressive it appears, and that's what's going to be able to give us the most accurate information as to what type of cancer you have and how aggressive is it going to be. We look at stage. This is stage. That means, has it spread? Is there any evidence that it spread to the bone? The bone is one of the most common places where prostate cancer is spread. Actually, most men, prior to the era of screening for prostate cancer, the way we found it was that men would come in with lower back pain. And that meant that the prostate cancer had already spread outside of the prostate to the spine. And that was very common back prior to 1980s as the initial diagnostic feature of prostate cancer. We look at the PSA, obviously, and their cutoffs is what's a normal PSA, what's a low-risk PSA, and then what's a high-risk PSA. Just to give you those numbers, most men should have a PSA less than 4. Okay, there is some age variation. Certainly, if you're younger, it should be much less than 4, maybe around 2.5. If you're much older, sometimes an acceptable range will even go up to 6, depending on the age. So if you're above the age of 80 or so, then sometimes I won't get really upset or worried about a PSA that runs around 5 or 6, because you've probably had that your entire life and there's really no significance to it. Of all the things that we've talked about, again, though, the Gleason Score is the most important. The Gleason Score is the microscopic analysis of the prostate cancer. So again, this is obtained using the biopsy. The biopsy is done in the clinic. The Gleason Score is made up of 2 numbers, and you get 1 score. So the first number of the score is the most prevalent form of prostate cancer that we find. So essentially, when the pathologist looks at it under the microscope, he may see several parts of cancer. Prostate cancer is very multifocal, so meaning that it's not just in one spot. That's why we can't just oftentimes treat localized areas of prostate cancer, because if it's in one spot, generally it's going to be in several other spots as well. So when the pathologist looks at it under the microscope and he says, well, here's the most aggressive type of cancer that you can possibly have. Here's the least aggressive type. The type of cancer I see the most of is going to be his first number. The second most prevalent form is going to be his second number. And so you get a score. Okay, and the score ranges from 1 to 10, or essentially 2 to 10 actually. 10 is the highest. We don't really call anything below 6 prostate cancer. So really your range is between 6 and 10 if you're going to be diagnosed with prostate cancer. The reason why I say that the Gleason score is the most important aspect of your prostate cancer that we know about prior to treatment is because if you look at this CauseSpecific Survival, which means did you die from prostate cancer based off of this chart. And so you can see at the bottom you go from 0 to 15 years and the percent survival drops significantly. So if you look at the 5 over there, so this is really why we don't call Gleason's 5 prostate cancer, because there's really no real decrease in the death rate. Gleason 6, you can see at the 5-year mark, generally there's about a 90% survivability. When you start going down to 7, it drops down to 80%, and scores from 8 to 10 more like 60% survivability at the 5-year mark. And you can see those numbers continue to go down as time elapses based off of the number, your particular Gleason score. So again, important for me to tell my patients and educate my patients is that most people won't die of their disease, though there are a certain subset of patients who will have an aggressive disease. And those are the patients who I want to treat the most aggressively so that I could potentially decrease their risk of dying from prostate cancer. Gleason score, again, determined by the biopsy, is the most important factor determining the prognosis for patients with localized disease. Cancer treatment, the goals of therapy. I think for me it's kind of a trifecta, meaning there's 3 things that I always try to emphasize when I treat someone with prostate cancer. Number 1, and the most important, is cancer control. So if you're going in to have treatment for cancer and you're not going for cure, then I wouldn't recommend doing the treatment unless it's just going to be something that's going to potentially make your life quality of life better. But for prostate cancer specifically, I always go for cure. That's my main goal. The second thing is continence. Continence is the ability to hold your urine so you don't leak urine. In the older days, prior to the newer advancements in technology, this was a significant concern. Is that if you had prostate cancer surgery, that you would leak urine after your surgery. I mean, that's quite a major change in life, and certainly a decrease in the overall quality of life. So that's one of my main goals, even over erectile function, which is the coitus part, is to make you dry, where you're not having to wear a pad or anything like that if you're having diagnosed with prostate cancer in treatment. And as we just alluded to, erectile function is intimately associated with prostate cancer and treatment, and obtaining good erectile function, I think, is extremely important for quality of life for some people, not for everyone. So again, the overall goal is cancer control, no treatment unless you're going for cure, in my opinion. The treatment options. There's a lot of treatment options, and we'll kind of discuss and go over the treatment options here shortly. But the treatment options are very much depend on several factors. Number 1, the age. So let's say that if you're 90 years old and you're just recently diagnosed with prostate cancer, I'm probably not going to recommend that we do anything aggressive. And that's because of those charts we looked at earlier, is that the risk of that prostate cancer causing you any shortness of your life is very, very low. More likely you would have some other ailment, including the heart and lungs and things like that would cause your life to end. Medical conditions. So if you're already a very, very sick person, maybe you're hospitalized and fighting another cancer or fighting severe coronary artery disease, aggressive treatment may not be the right answer for you. The Gleason score, we already talked about why the Gleason score is one of the most important considerations when considering treatment for prostate cancer. The volume of cancer. So when we do the biopsy, we not only get the Gleason score, but we also get the overall volume that's present in each biopsy. And certainly higher volumes mean that there's likely more disease. Remember, the biopsy is just a sampling. It's usually 12 pieces of the tissue, and that doesn't represent the entire prostate. It just represents a piece of it. So we want to know what the volume is. The PSA, also a good indicator. Again, there are low, intermediate, and high risk factors based on the PSA score alone. And then whether we can feel the disease or not. So that is why we do the rectal exam, unfortunately. So if we can feel the prostate cancer from the rectum, then that's a lot more concerning if we can't. So options for treatment. We're going to go over, these are all the main options for treatment. Active surveillance. So sometimes I've told people who come in, I've seen a couple 40-year-old men who I've diagnosed with prostate cancer in the last several months. And they had very low-grade disease, low volume, low PSA, and it just wasn't, the disease wasn't presenting itself as an aggressive disease at that time. So I said, look, we'll just follow this for a little bit. If it changes, then we can always do something, because we know the overall span and the way that prostate cancer grows and such. If it doesn't, then we may be able to save you from an invasive therapy, especially right now here in your 40s. There are strict criteria to going on active surveillance. So number one, you have to have a Gleason score of 3 plus 3 equals 6. So remember that lowest number that is defined as cancer. Number two, your PSA has to be less than 10. So that's kind of the low risk determination. If it's less than 10, then it's low risk. Between 10 and 20, that's intermediate risk. And then above 20 is much higher risk for the disease to have already spread. And then the volumes we talked about. It needs to be less than 20% of the total biopsy material that we've taken. 20 to 25% depends on who you read these days. But if you do go under active surveillance, it's a protocol of follow-up. Essentially, it's a PSA every 3 months and a rectal exam. And then at the end of 1 year, we rebiopsy and we see if has anything changed. The reason we do the PSA every 3 months is that if the PSA changes significantly or if the rectal exam changes significantly, then that's going to make us perhaps move to earlier treatment. And I actually had a patient here a while back, a gentleman who had very low appearing disease, low aggressiveness, and his PSA suddenly on surveillance went from 7 to 13, and that means it almost doubled. So now he's actually receiving treatment for it, and that's I don't think we've lost any time because of that. There's good statistics and good studies that show that this is a very viable option. And this is why I say not everybody needs prostate cancer treatment to be aggressive. Sometimes we can just watch it. Hormone therapy. This used to be one of the main ways that we could treat prostate cancer. And certainly since we were, in the older days, we were diagnosing a lot less prostate cancer early. Most of the disease was already spread, so it's gone to the bones, it had gone to the lymph nodes. In my grandfather's case, it had gone actually to his brain as well. Hormone therapy is essentially removing all of the testosterone in the body. So just like women who undergo menopause, that's the hormone for women is estrogen. Men have testosterone. That's what turns you into a male. It's what makes you chase women your entire life and think manly thoughts and all that kind of stuff. So by removing the testosterone from the body, what that does is it stops the progression of prostate cancer. It does not kill the prostate cancer cells. It does not cure you of the disease. What it does is essentially put the disease in remission, meaning that it should make the disease stop growing and stop spreading. That is an option for some men, and that's one of the reasons why that we're able to prolong the lives is because prostate cancer is so sensitive to testosterone levels. Now, the old-fashioned way of doing hormone therapy was that we removed the testicles, and that's actually what my grandfather had done. Luckily, nowadays we don't have to do that anymore. We can do what's called medical castration, meaning that we give you an injection, and the medication essentially blocks the production of testosterone, which accomplishes the same goal of removing the testicles. Hormone therapy can also be used in at least one other circumstance that I'll bring up, and that's in combination with radiation therapy, especially for guys who have more aggressive appearing disease. If you chose to pursue radiation therapy, then giving hormones in addition to it has been shown to decrease the mortality of prostate cancer overall. Cryotherapy, this is a newer treatment. It's essentially using ice balls or freezing the prostate. It accomplishes the goal of killing all the prostate cancer cells as well as killing the normal cells. So it is a localized treatment for prostate cancer. It does have some side effects. The side effects are erectile dysfunction is very high risk in cryotherapy. There used to be more side effects, but we've kind of got the treatment down a little bit better nowadays. It's not recommended as a primary treatment for anybody who has anything more than very low risk disease, and that's based off of the studies that have been published throughout the country. And so if you have low risk disease, this may be a treatment option. It's essentially done the same way the biopsy is done, except we do it in the operating room. We use an ultrasound to localize the prostate, map out the entire prostate. We get the borders of the prostate. We know exactly where the prostate sits. And then we use the freezing probes, and we freeze the entire prostate to kill the cells. Radiation therapy, there's at least two ways of doing radiation therapy. There's traditional external beam radiation, which is when you go to the radiation center, usually over the course of 6 to 8 weeks, 1.5 or so hours per day. You receive radiation to the prostate and the pelvis. As far as cancer control goes, external beam radiation is equivalent to surgery. Okay, it does have its advantages and disadvantages, and there are certainly side effects to radiation therapy. What I always tell my patients is that if you're a younger and healthier person, that radiation is probably not going to be the best option for you. It is a good option, though. The reason why I say this is because the side effects of radiation don't really occur until a couple years after treatment, and usually 2 to 3 years, and that's when you start seeing the effects of or the decline in erectile function. Men can have problems with urinary incontinence as well. They can have overactive bladder, meaning that they have urgency and frequency to urinate, as well as overactive bowels with frequency and urgency to have a bowel movement. It's for older patients, I think it's a reasonable cause. Certainly, patients who are not good candidates for surgery, if you have severe heart disease, but have aggressive appearing prostate cancer and would not tolerate the anesthesia that you have to have in order to receive surgery, then it's a very good treatment option. And I've sent many patients for radiation therapy. The other form of radiation therapy is what's called brachytherapy, and this is if you've ever heard someone say, I had the seeds implanted into my prostate. And these are radioactive seeds implanted the same way as the cryotherapy is done using the ultrasound guidance, and these seeds emit radiation over time, and they kill the prostate cancer as well as the normal prostate as well. Remember that radiation does cause essentially a big scar to form in the prostate and in the pelvis. So if you had radiation therapy and the prostate cancer recurred, you're really limited to your treatment options at that point, because if you wanted to have surgical removal, that means that's very difficult, meaning that because of the fact that there's so much scarring in the pelvis and the risk of injuring the bowels during the surgery and having severe complications is much higher. So most people will not receive surgery after any radiation therapy. You're really limited to hormone therapy after radiation therapy if you fail. Finally, the last thing I'm going to talk about from treatment is the surgical removal. The surgical removal has several ways of being done. I was trained to do the surgical removal in all three ways. One is the traditional form of the surgery, which is an incision below the belly button that goes down to the bone. We remove the prostate that way. I was also trained to do it between the legs, which sounds crazy that there's an incision between the legs and we can get the prostate out. But it's also a viable option for some men. And then what I think is probably the best way to do it nowadays is minimally invasive, or using the Da Vinci robotic system, which we'll talk about here shortly. Each option contains different risks and different benefits. Again, this is why I think it's important to talk to someone if you're diagnosed with prostate cancer regarding all those treatment options, and then how this is going to affect you, because how you show up to the doctor's office is going to affect your outcomes as far as which way that you choose to go if you were to be diagnosed with cancer. Each option should be carefully weighed, understand the risk. Patient preferences is very important. Some people say, hey, I've had friends who had surgery that was terrible. Some say, I had friends who had radiation and they say it was terrible. So a lot of it depends. Some people say I never want surgery. Some people say I never want radiation. So a lot of it depends on what you want when you come to the table after you understand all the options and all the potential risk and benefits. And then lastly, of course, is what I would consider the most important is the goal of cancer control. Removal of the prostate is called radical prostatectomy. We remove the prostate, we remove the tubes that hold the semen, as well as oftentimes we'll remove the lymph nodes that are associated with the prostate cancer. I think one of the advantages is that by removal of the prostate, we're able to see exactly how much cancer was there, what type of cancer, had it spread to the surrounding tissue, was it spread to the lymph nodes. So it gives us a lot more information after we have the entire prostate out as compared to just the imaging studies in the labs that we would follow using radiation. The major risks to consider, again, urinary leakage and erectile dysfunction. Other than that, there are basic surgical risks that you would have anytime that you would have any type of surgery.